from the Madison County Mental Health Board, and she will be presenting today on behavioral healthcare to justice-involved individuals. This presentation will be recorded, so those that are not able to participate today may also watch this at a future date. And I see you've got a hand raised here, Leo. I think we've got you muted, or your microphone is significantly low on volume. Yeah, you'll have to chat. Sorry about that. We are not hearing any sound from you. Okay. We will wait for that chat as we maybe get started, and then the chat will follow later. Sounds great. Okay. Deb, why don't you take it away?
All right. Oh, sorry. Can you see it?
We can see it.
Yes, we can see it.
All right, got it. Okay. The slides aren't advancing. Oops, sorry. We'll get there just a second. Okay. I just wanted to share, first of all, I've been involved probably working with behavioral health and justice now for probably about 20 years. And I say that, but also saying that even so, as Dana used to say, we know a little about a lot of things. And I'd have to say that still with justice, I'm still learning a lot as I sit with stakeholders that represent the justice system, and I am representing the behavioral health system. I've actually been able to participate in 5 pilot demonstrations with criminal justice and behavioral health in Illinois. 4 of them were Illinois, 1 was national. I actually work outside of my position with the mental health board. I've done contracting. So I've done 18 planning grants for adult redeploy with 18 jurisdictions, and 20 juvenile presentations for juvenile redeploy statewide, and also to all 50 states in DC. So had a wide variety of experience in relationship to that. So been able to work on developing 9 different courts in Illinois, 5 mental health courts, 1 drug court, an intensive probation program, a veterans court, an expanded veterans court, and a domestic violence court as different places where I've actually been able to work. And just looking at our system, you know, we look at the behavioral health system and we look how complicated, sometimes we know the complications of individuals navigating the system, how difficult that is. But then if you think about the integration of looking at the criminal justice system and all of the different pieces in navigating the criminal justice system, I actually tried to do an overlay, take a copy and copy the behavioral health over the criminal justice system, and how chaotic that can look and how difficult in the merging of the 2 systems can be very complicated. I wanted to give just a little bit of history, and I think everybody here knows this history if you've been in behavioral health. But again, looking at deinstitutionalization, you know, the goals in deinstitutionalization were really to provide better care for people, to have them live in a community, more humane care. But what actually happened by deinstitutionalization, where the act was created, where they back in 66, the Community Mental Health Act that passed nationally in regards to deinstitutionalization, it was called the Custodial Mental Institutions Act in 1962, which were replaced by community mental health centers. But the issue there was the services, the funding did not follow. And what ended up happening is jails and prisons became the largest institution for individuals with mental health or substance use disorders. We also saw that, when in that system, we know that individuals that work there, law enforcement, or individuals in the jail, they're not adequately trained to manage mental health issues or substance use issues. I have this with our local jail. We're in constant conversations right now. And some of the situations that we find individuals in are just inhumane. Sometimes, a person who's suicidal is totally stripped of their clothes and left in a cell for monitoring. And while we understand somewhat why, they don't want the person to die by suicide, but at the same time, being cold and naked in a jail. We had one where the person had feces and they were spreading it in the jail, but just different situations like that. It's just not a setting that's conducive or helpful for individuals with behavioral health disorders. So the trends, that we're seeing in terms of, I'm going to cover juvenile and adult as I'm talking. And we know that there's over 2 million children that are involved in our criminal justice system. We know what the mental health statistic looks like for behavioral health. 1 in 4 youth have some impairment with mental health functioning. And studies show that 2/3 of juveniles in the system have a dual diagnosis, and that's pretty. From what we look in Illinois, looking at 66%, somewhere 65-66% really is what we're looking at. So, due to lack of treatment and sometimes the lack of resources, like, and Jason, we talk about this, Jody, about the residential care for children and not having appropriate treatment for children. Our children are getting involved in the justice system as a result of that. So it's happening to younger people as well as adults. We know that parents have actually relinquished their rights and in the past, before the NB lawsuit, and juveniles were then they were finding their youth in prisons and jails as a result of, again, not having adequate treatment in Illinois. Trends in the adult system kind of mirror. If you look at the substance use issues, 63% of individuals in jail met the drug criteria for dependency. We also see with mental health disorders, 43% of jail inmates. We just did a study. The Southern Illinois University just did a study of our jail for us last year, and that's the exact number that we got from the jail was 43% of the inmates there that have mental health issues. In 2016, Illinois saw 71,000, a little over 71,000 individuals with new convictions, and 70,000, 89% were offenders. And out of that, they looked at 43%, again, of the mental health would reoffend in 3 years. Mental health and substance use, those individuals that were there would be looking to reoffend and recycle and recidivate and be seen in the system again. So the cost of incarceration, it is a concern. I mean, I know it's a concern for us at the local level. It's a concern for the state. But what we know in terms of juveniles, it's about $135,000 a year to have a youth in Illinois Department of Juvenile Justice. Comparably, some of the programs, the behavioral health programs or programs that are put in place can be accomplished with $5,000 to $6,000 and have much more impact and change in a youth's life than being in prison. A report by the Illinois Sentencing Policy Advisory Council estimated that the average cost associated with one recidivism event of an adult is $151,000. The cost for an adult in prison is a lot less, but when you start looking at court fees, attorneys' fees, and the whole justice system involvement, they're saying it's over $151,000 for an adult. So if you look at that overall, we're looking at, during a 5-year period, about $13 billion for someone who recidivates and is in the system. The council also estimated that by reducing the recidivism by just 1%, we could save $10 million a year. And so, again, not just not just looking at the cost, looking at, again, the person's needs and really helping that individual who has the behavioral health disorder is imperative that we do look at this issue and we respond to this issue. And I think, again, in terms of the community mental health and what our role can be, and I guess how I've envisioned my role in looking at it is, one of the things we do, and a lot of this parallels with the Community Mental Health Act as well, and what some of our responsibilities are. And so, one of the things that we've done, I started doing in St. Clair County, is being that administrative role for some of the grants. So here I have one grant currently that's administration, and that is the Juvenile Redeploy. But I also, we're doing now the Administrative Office of Illinois Court Grant demonstration project right now. It's our role to do community needs analysis. As I talk further and looking at, how do we address this? That's one of the foundational things that we look at in looking at how do we integrate behavioral health and working collaboratively and coordinating services in the behavioral health system with the criminal justice system. So that community needs analysis is very relevant. Community mental health representatives, having us and the collaborative relationships with the justice stakeholders, funding behavioral health services to jails and courts. Some of us do some direct funding, and I'll share a little bit later some of the funding that we do currently that we're doing with our justice stakeholders. Grant writing assistance, that's something that, again, that we've done not only in helping our organizations with letters of support and other things that we do, but I've actually got a grant writer that will work with our local agencies in terms of developing behavioral health resources in grants, and supporting behavioral health training for the justice, for public defenders, state's attorneys, law enforcement, jail officers. Those are all things, I think, in terms of the community mental health that we can play a role in doing. Some of the joint initiatives, again, that are possible joint initiatives. These are ones that I've been involved in. My juvenile involvement in justice started with a youth coalition locally and identifying the needs, again, of juveniles that were being incarcerated. And from that involved a juvenile justice committee. And from that juvenile justice committee evolved us going to the state's attorney and saying, we need to address this. We need someone that can really push this agenda, and evolved our Juvenile Justice Council in St. Clair County at the time. I'm now, the meeting I was just attending and coming into now is our Madison County Juvenile Justice Council. And when I came aboard here, they knew that I worked with it in St. Clair County. So they came to me and asked me, theirs had stopped completely and they wanted to reestablish it. So they asked me if I would chair that. So I've been helping them get that off the ground, developing a plan. And so we're moving forward with that. I worked with Station Adjustment, where we had behavioral health and clinical staff going into the jail when a child was brought in, and trying to prevent them from being, if they could offer some services, they would consider not charging them, and the child could go home with their family with services wrapped around the child at the jail. Redeploy Illinois, I know you probably have all heard about Redeploy Illinois, but that has been a major work that I've done in terms of trying to integrate behavioral health services and treatment and evidence-based practices into working with both juveniles and adults. Disproportionate minority confinement and contact. That was one of the demonstration pilots that we did in St. Clair County. Had the Burns Institute come in and work with us for a few years and trying to address that issue. Reclaiming Futures, that was funded through Robert Wood Johnson Foundation, and that's a private funding. And that was a national pilot that we did on substance use disorders for kids that are incarcerated, and working with our juvenile judge, state's attorney, and stakeholders there to try and address substance use disorders for children. On the adult end, I'm sure you're all familiar with task and treatment alternatives for safer communities. That one was more domestic violence that we worked with, but we did assessments, looking at assessments and behavioral health assessments for those individuals. Jail data link, that's a good assessment screening instrument. Not all counties have been there. I think there's 5 or 6 counties that are currently using jail data link. It helps identify individuals in the jail who have a history of mental health disorders or substance use disorders. It shows their medications that they're on. It shows their diagnosis. So it helps you do that identification right away on who's been in the mental health or substance use system. Problem solving courts, again, we have an array of problem solving courts from mental health court, drug court, veterans court. I know that Madison County was probably had one of the very first problem solving courts in Illinois. I mentioned adult redeploy. And then the Justice Behavioral Health Collaborative Program, that's the new one that we're just getting off the ground right now, working with our local jail. We have what we will be doing there is using the JDL, the jail data link, for identification. We also will have booking staff doing screening. We have evidence-based tools that will be done, brief jails, mental health screen. And then we will have what will be called an engagement specialist. That person is a certified recovery support specialist, and that person will be, again, after they're identified, they'll be meeting with them. They'll be looking at what services they need while they're in jail, but the biggest emphasis will be on reentry and what can we do to get that services coordinated as that individual's leaving the jail back to that number that I talked to about the recidivism and the rate of repeat for individuals. It's a revolving door for individuals with behavioral health disorders. They get back in the community. They don't get into treatment, and they are just rearrested and they're back in the jail environment. So they just recycle back through. And then central deflection, it's not exactly looked at as probably as a justice initiative. It's coming, again, task is kind of leading that effort as well. But if you're familiar with that, I know here we have just, I think, 3 individuals assigned to a very wide area, but there's supposed to be people on the streets identifying individuals before they're arrested and trying to get them linked with services. Behavioral health will be a big component of that, as well as other services that they might need in terms of looking for housing, financing, different issues that they might face. We've just been in the part, again, this is new in Illinois. So it's going through just that development of any organization, mission statements, goals, and that type of thing. Denise is representing us. Denise Bradley from my office is representing us in that effort. So potential services and supports that can be come about as a result of behavioral health and justice working together is, looking at, and some of this through grants, or whether it be through mental health board funding, looking at funding counselors, case management, I mentioned engagement specialists, looking at employment of certified recovery support specialists and psychologists. And I know here we have funded some of those components, and I'll share that a little bit later. Again, other things that we can do is funding education and training. We are looking at hugely at doing training for law enforcement. In some of the grants, we did electronic monitoring, so they don't have to be in the jail environment, so they can at least be at home, which is a much more conducive environment than being incarcerated. The evidence-based practice therapies, funding and supporting those. Incentives, we know that the judicial system has in the past really functioned off of sanctions, and that's one of the big changes that's come about through our problem-solving courts, is that we have incentives and look at let's reward and motivate people to change versus always being punitive, and that's been a big change that's come about through that. Medication support, again, some of the grants that we have written are, for example, our adult redeploy, we always include funding for medications, and those again are fill gap. We know Medicaid, if they're not incarcerated, if they're Medicaid eligible, we know that there are funds for that sometimes, but then there are times that individuals are falling through the crack, and so we have had medication available, paying for testing like substance use disorder testing, urine analysis, and then transportation, buying bus passes, and some of those essential things that every meeting that I attend, every time a group comes together, the biggest things they say is transportation. They can't get to their appointments. And we know, again, for mental health, there is that Medicaid option to do that, but then there are still people falling through the crack at times. So some of the goals and outcomes, again, in bringing behavioral health and justice together, I think one of the first things is just building that collaboration between the justice and behavioral health stakeholders. That's kind of like just the basic first step of anything that you can do. And that's not an easy thing to do. We come from very different worlds, from very different perspectives. I know the probation, the first time I was working with them, say, oh, you guys are just social workers. You want to help everybody. And, not everybody can be helped, and trying to change some of the thinking over time, that takes some time to build that rapport, to build that trust, to build those relationships. Identifying individuals with mental health disorders at risk or involved in the system. Again, back to that assessment piece, and screening and assessment is really essential for identification. Ensuring appropriate behavioral health treatment during incarceration. That's a real hard lift, and that's something we're working with our jail again right now. They're saying we need mental health treatment. Problem is they don't want to pay for it either. So how do we make this happen? How are we going to meet together again in a collaborative way and say, how do we provide for the needs of mental health? My budget has a limit, and their budget probably has a limit as well, but we need to really determine how do we make this happen. Guarantee a comprehensive behavioral health plan or reentry plan upon release. So if they are imprisoned or in jail, that plan is essential to really looking at what are their behavioral health needs, how are we going to address those, how do we address them in the jail environment. We have advanced practice nurses functioning in our jail. They do not feel comfortable prescribing psychotropics. So we're looking at, can we do video and have the doctors from Chestnut Health Systems come into our jail and be prescribers that way. They can't afford to have an APN housed at the jail or offering services, but they can do that. And so some of the outcomes that we're looking at, for behavioral health, again, is that service collaboration, service coordination. That's one of the things that rose to the top of our community needs analysis locally, again, is we have a lot out there, but it's not very well coordinated. So how can we improve on coordination? Reducing the number of individuals with a behavioral health disorder from even getting to that door. I mean, if we could again do something earlier, intervention or preventative services, what that would really help us in terms of reducing that number. And then that reduction in that recidivism, that revolving door of individuals utilizing or being committed or to incarceration. So again, here's just an overview of some of the things, services, supports that we're looking at for this year. Again, that engagement special I talked about, the choices, central deflection. Again, my being a leader representing behavioral health in juvenile justice as a co-chair there, constantly addressing behavioral health needs of youth that are in our justice system. We have our judges there, we have state's attorney, public defender, we have all the key players there, bringing this in front of them. We had just finished a meeting, had a really great meeting on some potential things we're going to do at the truancy level with youth. And again, these are youth with mental health issues, and the numbers are just still within our schools. Mental health is just here. I'm talking to teachers. it's just really, really bad. I've talked with counselors, and we're still seeing such a heightened number of youth with behavioral health disorders. Our detention center, the mental health board funds a position for art therapy there. They have a full program. The behavioral health program has functions in the evening. They have school all day, and they have in the evening, they have a behavioral health component where they're either in individual therapy, they're in group therapy, a group called Calm. And then we have art therapy that we make available. And then through a grant that we have, that's a flow through that we are administrating, we have counseling that is done through a graduate intern that we keep there 20 hours a week in detention. So mental health court, we fund two case management positions in mental health court. Law enforcement, we've done, we've funded them $16,000 is what we put into training this year. And we actually had our CIT trained officer out of one of our jurisdictions took the lead on that. We said, if you do it, we don't want it just for your jurisdiction. We want it for all of Madison County. So they have done that. And we've had hundreds of officers trained this year, trauma trained, crisis intervention trained. There's a training coming up into February where they're bringing together the hospitals, the crisis, anyone working with crisis to come together with law enforcement to say, again, how can we work together, coordinate, and meet the needs of individuals with behavioral health disorders? And so a big emphasis on our training. They brought in Bridgepoint to do trauma, which was a 2-day training that they did, which was what I heard from a wife of an officer is that I wish I would have had it 15 years ago when my husband started in law enforcement, because now I understand as a family member, when my husband experiences trauma, how I can relate to him. The opioid remediation settlement, we have that funding. So we will be working with our providers and putting out RFAs actually this week, we're going to be putting out the RFAs for that. I skipped our drug court. Our drug court's named Madison County Assessment and Treatment Alternative Court, but that is our drug court. And we fund 100% of that court, all of it. That's probably the largest thing that we fund in terms of mental health justice. I'm sorry. And then Redeploy Illinois, which I kind of talked about already. But I want to talk about just the fundamentals and how I've worked with behavioral health and justice. This is kind of the format I use when I work with planning, in the planning grants that I've worked with some of the startups of some of the problem solving courts, and just the fundamental type things is, I talked about the key stakeholder, and really that is, like I said, first level is building those rapports. And the second level, again, is that assessment, looking at your community, looking at your justice system, your local justice system, what that looks like. And what I reference is community mapping that I do with every jurisdiction that I go and work with. And then using a planning model, the stepping up is one planning model. Our county refused, did not want to work with stepping up with NACO. Has that, and then an implementation plan. But I work more with logic models and doing our planning. Back to key stakeholders, again, these are people that I think that are essential to being part of whatever you do with behavioral health and justice. So these are your key justice people that you want to have involved, your judges, your state's attorneys, again, law enforcement, your sheriff. The higher up you can go, the better impact I think that you have. If you can have the actual sheriff there, that's your best. If not, if you can get the deputy underneath the sheriff or someone, again, that can actually help you move things. On the behavioral health end, again, having your treatment providers, and I say administration and clinicians. I think you need both. You need administration to be able to move things again. If there's decisions to be made, if there's funding to be allocated, you want your administration there, but then your clinicians have so much to offer from their level and perspective of what they see and what works. having psychologists representative. I know for forensics, we've always had a psychologist sit on our court teams and the development of our courts. And then other really key stakeholders is community stakeholders. There are some community stakeholders that are very invested. You know, some of them, I mean, we have some retired judges that have been involved, county board members that have an interest, non-for-profit organizations. We have a lawyers non-for-profit kind of organization that's developed that actually have helped fund grants, grant writers to write grants to bring in revenues. And universities have been not only from the evaluation and data collection, but also for grant writing as well. They have partnered in it and have written grants, and we're actually looking at a BJ grant right now with our local university. So they each bring something unique and usable for the work that you're looking at. In terms of assessment, this is a sequential intercept model, and if you work with criminal justice, you're familiar with this, but really it's taking a look at that whole continuum of criminal justice, looking from what's happening at the community level. We have some store owners in one of our cities that's just up in arms because these mentally ill people and these alcoholics are right in front of my store. Well, the store is a liquor store. And so they're up in arms because these people are just sitting there and it's hurting their business. So what's happening at that community level, looking at that intercept one, law enforcement, what happens when a person presents to law enforcement? What are we seeing there? Again, what happens at the detention level, at court hearings, and just go through the entire system. And that's what we do. We go block by block. What does it look like in your jurisdiction? What is happening at each of these levels? Because that's the assessment information. You know, if you're going to be looking at what are the remedies, what are the strategies, what are the things that we're going to be doing, we have to know what issues lie in each of these areas along that continuum of the justice system. Community mapping, then the other piece that I usually do is really look at that community and what are all of the resources that they have available, because by looking at what they have available, you also find out what is not available. What are the gaps? What are the needs? What are the things that we don't have, that as if we're looking at partnering, you know, what again do we need to look at in terms of funding and resources to bring about to serve the individuals, so that again, say for upon reentry, you know, is that person, they need to be linked, so they need to be linked with the behavioral health, they need medication, but they're homeless when they go out the door, they don't have a place to go. I didn't mention community development. We have employment and training. We have community development as, again, some of those other key stakeholders that could be at the table to help in terms of what's available in the community. If it's getting them hotel nights, if it's getting them those bus passes to get somewhere else where they can be domiciled. But that the community mapping is generally the second thing I do after going through the sequential intercept model and identifying the justice system, then looking at what else is available in behavioral health, and in human services that can support a behavioral health and justice initiative. Some of the evidence-based practice and tools, then these are some of the things that I've worked with. There's lots that I don't have on here that I've worked with. These are just some examples. And again, each stakeholder group that I've worked with, each jurisdiction usually has different things available. It's different tools that they use, but that's a starting point, and is identifying, okay, what are you using? What behavioral health screening and assessments? But these are some of probably the ones that are more utilized right now. The brief jail mental health screen I mentioned, global assessment of individual needs screen. That's a very short, there's a SS screen. It's a short screen. I think it's 4 or 5 questions that identifies if the person has a behavioral health disorder. A new one to me just came about with the AOIC grant that we're doing. This is one that they're using tobacco, alcohol, and prescription medications and other substances, which is a screen. The IM cans. The justice system uses Ohio risk assessments, and I do have it lower, the LSIR, And so they're looking at risk, and they look at risk through what can we do for rehabilitation, but they're looking at some of the same things that we look at in behavioral health, in terms of employment and where they're going to be, you know, different things that set them up for being risk of recidivating again. So psychological assessments, again, in every grant that I've written with justice initiatives, we have psychological assessments factored into that because we know these individuals will need a psychological assessment. Assessment and planning, again, the LSIR probation uses that, and that again is one that really looks at different domains, and it looks at how do we look at rehabilitation. There's a Casey planning that actually helps develop a plan and a reentry plan. We've looked at wraparound planning, which for juveniles, we actually use the wraparound planning for our redeploy program. And making sure, again, looking at all the domains of what the child needs and making sure that we address each of those needs in that wraparound plan. And then WRAP, as in the Wellness Recovery Action Plan, and instituting that with adults who have a mental health disorder and helping them develop a plan on what will they do if they start to have symptoms or difficulties. You know, how are they going to develop their own recovery plan and work through their own recovery plan? Other evidence-based practices, this is on the justice and motivational interviewing. They call it MI. It's their work. It's really supposed to be evidence-based in helping in engagement. How do you, at the very beginning of working with someone with a behavioral health disorder that's in the justice system, or anyone that actually comes into the justice system, how do we engage them in working with them towards rehabilitation? Therapy, there's again number of therapies that are developed for criminal justice and behavioral health. And multisystemic therapy, we used that for years in working with adolescents and youth. We used family FFT as well, functional family therapy, but that doesn't seem to have worked that well with justice involved youth. Recognition therapy, working with substance use, individuals with substance use disorders. Cognitive therapy, there's a number of those as well. Thinking for a Change is one that we used in St. Clair County, and then trauma therapies. Also, in terms of treatment with medication, medication-assisted treatment, medication-assisted recovery, you know, we've tried to do that with our local jail and unsuccessfully so far. We're going to take a shot at it again. We've had a change in sheriff. We've had a change in the deputy under the sheriff, and they're very much more open to mental health, and hoping that we can go back and try again and say, is this something that we can look at for individuals that are incarcerated, and starting that medication-assisted treatment and then being able to continue with it after they leave the jail environment. So funding, lots of opportunities for, well, lots of opportunities. They're very competitive most often, but there are opportunities for funding. Bureau of Justice and the Substance Use and Mental Health Administration have grant opportunities. At the state level, again, the Administrative Office of Appellate Court, with, you know, with Scott being there now, Scott Block, and that behavioral health component developing. I know that they're really looking at how can they expand and provide funding for behavioral health through the Administrative Office of Illinois Courts. You know, our grant that we got was very small. It was barely enough to cover the position, but it is demonstration, and I know that they are looking for their dollars to support that. Illinois Criminal Justice Information Authority, again, funding adult redeploy program. I've actually received funding from the Illinois Juvenile Justice Commission, and we've actually had JDAI grants before, Title X grants. So there's lots of other smaller grants that are out there. Substance Use Prevention Recovery, SUPRA. I know that they're working with the opioid as well. but there's some funding mechanisms through that. I know one of the things that they're doing here locally is the Oxford houses. And so again, with individuals needing that residential component, we are having a growth of beds here in Madison County. And then through the county, again, us as community mental health authorities. And I mentioned, other county offices, our community development having funding, and our employment and training also having different types of funding available for apprenticeships, training, helping individuals. Again, if you're doing a reentry plan, there might be individuals that you can look at furthering education. I know some jails actually have education programs embedded in them. I'd like to see something like that here. And again, that's usually more beneficial for individuals that are going to be incarcerated, for more than a year. And that does happen. We do have individuals that are there for a couple of years at times, depending on their charges. So taking all of that assessment information, taking the planning information, looking at your evidence-based practices, gathering all of that up with the jurisdiction, and then looking at a logic model and just looking at, okay, what again do we have? What are the inputs that we have, in terms of funding, in terms of personnel, in terms of stakeholder, here's what we have that can help us with growing behavioral health and justice initiatives in our area. And then looking at what are the activities, what are those things that we really want to target or focus on in growing to address individuals who are incarcerated or in the system. And then what would the outputs, how do we measure that? How do we know, and what are we reporting on to know that we're having an impact in addressing those? And then just, again, looking at short, medium, and long-term goals, what are the things that, again, are going to help us immediately in diversion, prevention, intervention here, those short-term things. And then what medium in reducing, again, the ultimate goal is to keep them out of being incarcerated, keeping them out of jail, keeping them out of prison. And then the long-term impact is just really that safety component for our community, the greater public, our community. And then you can see, and I don't want to read all of it, but you can see just some of the other things that we look at. And this one, I think, was Montgomery County. This was the most recent one I wrote last year with them. And this is what we established as our logic model to address that there. So that gets me to questions. I
think we had a couple, one from Sharon in the chat room, Debbie. The county doesn't help cover any drug court costs, example, through fines, fees, or other budget allocations.
I'm sorry, say again, Jody.
Sure.
They don't cover, is she looking for suggestions? Is that the question?
The question was, the county doesn't help cover any drug court costs. And she's saying through fines.
Hi, it's Sharon.
Yeah.
I thought I'd just jump in. You had said that you cover all the costs in the drug court, the mental health ward.
Yes, 100%.
Okay, and the county doesn't, that's not part of their budget at all. It's strictly mental health supported.
It's in my budget, but the county has to levy that money. That money's levied through the county to us through our tax referendum.
Okay. Okay. We provide some funding for the drug court, but the county board itself provides some funds, and then there's some funds that come through, a limited amount through fines and fees to help support that. I was just curious when you said that, how it is actually being funded. And then aside from the drug court, are there other things that you're funding through the county itself? Not in terms of other nonprofits, for profit or nonprofit behavioral health providers, but other things you're funding through county government.
Well, I wouldn't be funding anything through county government. I would just be working off of our levy. I'm trying to think, I mean, the county jail has funds, you know, if they're providing mental health services. In fact, they had a contract with a company, ACH, Denise, correct, who provided mental health crisis services in the jail. And Denise actually, previous to coming here, did that work there. I mean, they support the judicial system, you know, they support, you know, those positions and various positions like the problem solving court coordinators and things of that nature.
Okay.
I can say
Thank
that,
you.
you know, how it evolved here is that there was a grant for drug court. And then they decided that they wanted to sustain that as a county. And so they gave the money to the mental health board in our levy for us to administer that. Does that make sense?
Yeah, I think I have a pretty good picture. Thank you.
I had a couple
And I put the,
comments.
Oh.
I just want to thank you for the presentation. It's so comprehensive and it's so knowledgeable. And I really want to thank you for sharing all of this information. I wanted to share that you may have seen in other updates that that California has been the first state to get an 1115 Medicaid reentry waiver. Yay. And that federal CMS is going to issue a state Medicaid director's letter with guidance for other states to tell them basically how to write a waiver to increase the chances of being approved. So Illinois tried to do this a couple of years back, I think in 2017 or 18, something like that, and failed, but everyone was failing at that point. They weren't giving these out. So that is huge news. That is like a change in landscape. And the California waiver allows 90 days of coverage, which is, I think, more than was anticipated. So that's something to watch, I think, and something for the legislative committee to think about. The other issue that I just wanted to ask, if anybody has heard about this, you may remember I worked for Task for like almost a million years in my previous life, and an issue came to my attention about jail-based opioid withdrawal and what a problem and how dangerous it is, what a problem it is. And we did a little research and wrote an issue brief on it. And it was, what we learned was it's very, like, nobody was really counting these instances. You know, there were horrifying episodes, some of them caught on video in institutions where people were dying. People are dying from this. And so the medical literature is being updated. Previously, it has said, you know, people don't overdose, people don't die from withdrawal, but it turns out people are dying from side effects, et cetera. You know this. So I don't have a good sense at this point, though, of whether the needle has moved at all on that. And what we do know is that overdoses are going up and that fentanyl is a bigger problem than it was before. And like on that end of things aren't improving. So I have to think that I wonder if anything is changing in jails or whether that is being added to the assessment when people are coming in anywhere. I just don't know. So I wondered if anybody here knew or if that's on your radar, that issue.
So I can speak for our county jail. That is one of the very first questions they ask. I will say a lot of people deny. And then, as you know, here comes those violent symptoms. So while the Madison County Jail does not offer medication assisted treatment, they absolutely have, I think, 2, maybe 3 different medications to help with that withdrawal. And then worst case scenario, they start getting dehydrated, they immediately send them out. So
okay. Thank you.
One of the other concerns is, again, upon release, if they're not engaged into treatment again, this is for reentry again. If they haven't used, they go back out and they try to use at the same level they did last time, and that's death.
Yeah, totally. Yep.
So that's another aspect of it.
It's why connection to medications, honestly, is just sort of such a priority. And access to medications in carceral settings is such a priority. I know you said they don't do it. I think there is some movement on that across the state where some are more open to offering an array of choices and, putting, programs in place that bring access to either methadone or Suboxone, as opposed to just Vivitrol, which is sort of what we've seen previously. But I think those are important issues to think about. Yeah, thank you.
And thank you for the information on the Medicaid. I had not heard that, but that really does, because I know in our last, I think, Ron, in our last executive meeting, we were talking about that, and Lynn said that NACO or NACBID had been working on that for some time and had not made any progress with it in DC. So with California leading, hopefully more will be able to follow suit with that. That would be awesome if we could do that.
There's a whole bunch of criminal justice side advocates who've been working on it as well, which is kind of what it takes, is the partnership between the two sectors, I think. So
Yep.
Yeah, I mean, Cermak Hospital in Cook County Jail does have a detox unit, but I don't know how effectively they assess people or treat people. And they have started, at least on their website, they say they've started MAT as
I think
far
they
as
did.
discharging people. But again, I don't see any numbers or know how effective that is in Cook County. I had a question. I certainly enjoyed and really like the way you put together everything. It was very helpful. I like the juvenile and the adult. I know it's been about 10 or 11 years since they cut funding, but for 50 years, the Unified Delinquency Intervention Services program was a strong program across the state of Illinois, with many counties participating, in Illinois Youth Service Bureau, and Illinois, and other various providers. I was a UDIS advocate in the 70s and 80s and then ran a program in the 90s. And it was a wonderful program that they defunded about 10 years ago and then pushed the responsibilities into CCBYS, which is supposed to be a runaway youth program and not have any juvenile justice involvement. And I don't know if anything has evolved from that, if that's still listed as a CCBYS program or if it just was defunded and died. It certainly would be worth looking at it, bringing it back. It was 10 hours a week of funding. It was a funded wraparound plan in essence.
Yeah.
And they would pay for counseling, they would pay for detox, they would pay for anything. And I had many kids successfully go through that program.
It hasn't come back, but I know that individuals that have done that work in the past have really keep bringing that up for discussion and keep, encouraging to bring that back. Redeploy, juvenile redeploy, again, is somewhat along the same line of some of the things that you can get from that in terms of services. It kind of mirrors that different population, but still gears itself towards that. But, in St. Clair County, when we started, we had 90 youth being committed to the Department of Justice for youth. In a year later, we had 10 youth. And go back to that number I shared about the cost.
Sure.
And just look at that. How much more can we do with behavioral health services with that same kind of money? They promised us that if we did well with this, and the state makes promises, and they said, if you do well with this, that money that you're saving, you will benefit. We'll bring that back to the community. They have done that. Every year that we've asked for additional services that we feel we could address another need for youth. Again, if it's an evidence-based practice or something that fits, they've approved it. They've not disapproved one thing that we've asked for kind of expanding that for youth that are in the justice system.
Oh, good.
So that's been very beneficial. And I know here we are only committing 6 youth, and our detention center, which has 52 beds, has less than 16 youth in it. So we are trending down. We are making an impact. So that's great. I think, again, on the adult end is probably, again, we're probably more emphasis and working. Again, if we can get things like that, 1115 passed and get some reentry programs and do more on the behavioral health end with the jails, I think we can even have a much greater impact.
Okay.
Debbie, we had Mark Avalar raised his hand. He's the new president for Dundee Township. Welcome, Mark. I think you have a question.
Yes, thank you, Jody. And Dundee Township is in Kane County, just for those who may not be familiar. Question first, I want to thank you for the thoroughness of the presentation, and certainly look forward to having a copy of the deck if as a follow-up. But a couple of things. You mentioned that in Madison County, the drug task force was not funded. You received a grant, and then your county board added that to your community mental health fund. Did I hear that right?
They actually had I believe it was a Bureau of Justice grant. This was predating me. I've been here for 3 years, so a lot of this is history. But the funding then, they wanted to sustain it. You know, usually every grant you get, they say, what's your sustainability plan? And most often you get there and there's no funding when you get to the end. But in this case, the county did say this is a program service docket that we want to continue to support. And we have a great court. We had 23, 24 individuals graduate. They've had 2 graduations this year of that number. And several of them said they had 6 children in their family. So multiply that out, the impact it had further than just the individuals that were involved in court. Just really changing lives. And so the county decided to put that amount of money into our levy. And so that levy, I have a specific fund, but in my budget for just the alternative drug court, and all that funding goes directed to the court.
Okay, so it did not reach the cap, the PTEL cap, where you had to go to referendum to increase your levy?
No.
It was within the cap, is what I'm hearing. Okay.
Yes.
All right. And second, and this might be more with the state versus local, but one of the needs we have up here is the involvement of family for treatments. And we're finding, and part of this is the COVID emergency, which we all know ends on May 11th, thankfully. So maybe with those rules were relaxed, but are you finding that in downstate, or has it been a case where you can't get enough family members to help patients, particularly adult patients?
Well, I think historically in mental health, let's just look at mental health by itself before they become involved in the criminal justice system. A lot of families aren't there to continue support to them. They become worn out from, adult child, that has a mental health issue, and their support system generally when I've seen them in the criminal justice system, they don't have a support system anymore.
Okay.
I think in some cases, maybe in jail, Denise, maybe you see them at the very beginning, but I think the longer they're in the system, the less they have support from anybody.
Okay. All right. So it's just more, and I know it's a one-off but I just wanted to see what you're hearing down there. It is unfortunate, but like I said, when we have family or loved one support to help our patients, and that's something we're trying to advocate here. So again, thank you so much for taking the questions, and that'll be all for now. Thank you.
But Mark, that's a very important thing that you said, that if we could do work with individuals earlier before families are burnt out, when caregivers are burnt out, if we can employ things to bring the family and support the family. With one of the Redeploy initiatives that I wrote, we actually had NAMI written into it to do parent education and do parent supports to try and work with them while they were in the adult redeploy program. It didn't work because, again, we couldn't get any referrals with individuals that had family members that were there. So I think earlier, engaging families earlier before the point of exhaustion or burnout in caregiving stress.
Okay. Thank you so much.
Are there any other questions or comments for Debbie? like none. Debbie, it was a great job. Wonderful presentation. I have this recorded and we'll post this to our YouTube page. I'll send out the link. And if you wouldn't mind sharing your slide deck, I will send that out with the link to the recording.
Will do.
And our next meeting of the Communities of Practice for Crisis Reform is March 20th at noon. So we'll be meeting again then.
Okay, thank you.
Okay, thanks everybody. Thanks, Debbie.
How about you?